Imagine you go in for a routine skin check. You're in the exam room, gown on, and your doctor finds a spot. Irregular, changing, the kind of thing you want to deal with now and right now. That's exactly what happens in our offices and many dermatology offices across the country. We'll numb it, biopsy it, it goes to the lab, and you go home having it all taken care of in one trip. Now imagine that you're told instead, that looks concerning. You have to come back in 2 weeks and we can do the biopsy then. Same spot, same worry, but now it's a second appointment, a second copay, another day off work, another long drive, and 2 more weeks of not knowing. That's not hypothetical. It's what a new Medicare proposal this summer would push doctors to do starting in 2027. Not because anyone wants to, but because of how care gets paid for. And the public has until September 14th to weigh in. Today, we're going to walk through what this new rule proposal by CMS actually says, why it hits patients the hardest, and what you can do about it before the window closes. If you're new to the podcast, I'm Dr. Dustin. I'm a board-certified dermatologist and owner of Treasure Valley Dermatology, and I'm joined by my co-host, Austin Lee.
I'm Austin Lee, physician assistant and practicing dermatology every single day, but frustrated with some of the things that we have to deal with these governmental changes.
Now, we don't want this to be all doom and gloom. We do believe that there's hope that you can do something about the way that you get care. And we're going to kind of go through what the government is proposing and why this impacts you, not only if you have Medicare, but if you have private insurance, because whatever Medicare does, private insurances tend to follow. Mm-hmm. So right now I want to break down how we do billing for an office visit. When you come in, and let's give a scenario of you have a rash and the doctor sees you, diagnoses you with eczema or psoriasis, prescribes a medication, you leave, go to the pharmacy and pick it up. We'll bill your insurance for an evaluation and management code. And this is simply the computer language that tells them, we saw you, we evaluated you, and we managed the problem. And this is primarily for medical type things like rashes, skin exams, acne. And so we'll bill something called an E&M code, like a 99213 or a 99214. If it's a very low acuity problem, a 212. And each of these are paid at different levels by Medicare and by the private insurances. Now let's shift that scenario a little bit and assume that you came in and you were being evaluated for the exact same rash. But during the course of looking at your skin, the doctor finds a mole that looks really concerning. And the doctor tells you, I think that this could be a melanoma, and I think we need to do a biopsy. So what we would do in that case is get your consent to do a biopsy. We would numb you up, we would take the spot off, send it to the lab, and get results in about a week. Mm-hmm. We would then send in the evaluation and management code, just like we would before for the rash, and then we would bill the biopsy code for that procedure, which is completely separate from the rash that you had. And then we would attach to that something called a modifier 25. And this is, again, just a computer code that tells them the biopsy that we did is not connected to the problem that we were managing that the patient came in for. And right now, according to the current rules, the government, CMS, and private insurances pay us for each of those procedures. Mm-hmm. But what they're proposing to do is to say that if we do a procedure on the same day, and we're using that modifier 25, that we'll only get paid 50% for whatever is less expensive, whether that's the procedure or the office visit. Mm-hmm. And now the purpose of this is not to talk about what we get paid. Doctors are still high earners. Medical providers are still high earners, and we're not looking for sympathy, but we're trying to bring to you the real world scenario as to what this means for patients. And that is that when you decrease that second reimbursement by 50%, this puts many practices into the red, meaning we're not making enough money to cover the overhead. And so just because you have a procedure done on the same day, it doesn't mean we're not opening a new sterile package. We're not paying for the same amount of staff time. We're turning over the rooms, the cleaning supplies, the medical supplies. All of that stays the same. And now the reimbursement from Medicare and private insurances will be less. And so if a doctor in their office can't actually make their overhead when they come to paying their staff and their medical equipment, you'll be asked to reschedule that procedure for a later date. And if you're seeing a busy office, there's a high likelihood that you could wait a couple of weeks, if not more, to come back and have a biopsy done for something you were told, I'm worried about. Now, CMS calls this an efficiency adjustment, and they think that we are basically price gouging, that we're
taking
already
advantage of
we're already
the opportunity,
doing the evaluation, and we're just getting paid for it twice, which is simply not the case.
Yeah.
In this scenario, we have a rash that we're treating. We follow the billing guidelines for that, and then we do a procedure on something that is completely separate. Now, I want to make you aware that already, if you come into a dermatology office, this is the way it should work, and it's the way that we do it. And let's say I have a wart on my feet, and you want that wart evaluated and treated. We would be able to do that on the same day. And if we're not looking at anything else, you're only getting billed for the procedure.
Yeah.
Because the evaluation of that wart and saying, yeah, that's a wart, is included in the procedure code. So this deals with scenarios where you are addressing two completely separate things.
Yes. And this is something that we see on a daily basis.
Yeah.
And very many of you have probably experienced this, where you go in for one thing and your provider finds something else to address that is concerning to them, or that you need to have addressed, just weren't aware of. Mm-hmm. Just today, I could probably think of 5 patients offhand where they came in for one thing and we find something else that needs to be biopsied or frozen or treated. And so this is not a scenario where they're changing these rules and it's going to affect a small subset of patients. It's going to affect the vast majority of us and you as patients.
And it's important to remember, this rule is not just affecting dermatology. This is nationwide, that affects all doctors who take Medicare and private insurance. And so it's going to affect your primary care visits. It's going to affect your cardiology visits, any specialist that you see. If they normally would be able to do a procedure on the same day, then you're going to be asked to reschedule that, because practices will literally not be able to keep the lights on if they have to abide by these rules.
Yeah.
One of the common examples that I saw when I went through my ear, nose, and throat rotation is that patients would come in with sinus trouble, with throat trouble, with trouble swallowing. And a common procedure for an ear, nose, and throat surgeon to do would be to use the laryngoscope, where they put a camera in your nose and they look down your throat to see if your muscles are working okay, if there's any obstructions, if there's any growths in your larynx. And this is the type of procedure. Now, if you're coming in and you have trouble swallowing, now you're going to be asked to come back weeks later to have that proper exam done by the ENT. Mm-hmm. And so this is not just a dermatology problem.
Yeah. Another very common scenario that people will encounter is if you bring your child in for a wellness check to their pediatrician, and the pediatrician examines the child, but then this week they developed a rash, or they developed an ear infection, or they have a headache or something else going on, they're going to have to come back to be assessed and treated for that additional complaint.
Yeah. Your well child visits will have to be completely separated from your sick child visits.
Yes.
You won't be able to do both at the same time. And so I want to kind of drill home the impact of what this will have on patients. And I think that this is really applicable to patients in our area, but especially anywhere where there is a rural population. So it's first off going to require a second trip. And that could just be more time off work. Could be more time off school if you're bringing your kids in for acne and for a skin check. If you have to drive a long ways to see your doctor, it's going to require additional drive time. If you're somebody who cares for somebody else at home, you have to leave them again, or you have difficulty transportation. You're going to be waiting longer periods of time for answers that you're concerned about. As I said right now, if we do a biopsy on the same day, we can often get results back in a week. But now we might be in a scenario where patients have to wait 2 weeks just to get the biopsy, and then an additional week for results. And so if we're concerned about a skin cancer, then we're now 3 weeks later in getting that diagnosis and instituting appropriate treatment. And then we're going to have longer waits in all specialties, because now instead of a patient getting everything done all in one visit, they're going to have to come back, and that's taking up 2 office spots. So if you're trying to get into an office for the first time, they're now more overwhelmed, and there's fewer spots on their schedule to get new patients in.
Yeah. It's gonna clog the whole system. One of the things that I really enjoy being able to do as a provider is take care of my whole patient in one visit. And these proposed cuts are going to really limit what we can do in a visit. And that's incredibly frustrating for the patients. It's incredibly frustrating for us as providers. And our job is always to do the best we can to take care of our patients. But like you were saying, if it's going to make it so that these, especially more private facilities like us and like smaller private clinics, can't pay their overhead, then you're going to start seeing this type of adjustment, and it's going to affect everybody, every specialty.
Yeah. So some things just to understand. So half pay doesn't really cover those non-optional costs, the sterile medical equipment, the staff overhead, salaries, retirement benefits, insurance benefits. I think we do a really good job in our office because we pay the full health insurance premium for all of our employees.
Yeah.
We have a 401k where we do a match. And if we're no longer profitable at all, there's going to have to be either staff reductions, there's going to have to be benefits reductions, and we don't want to do that to our staff, obviously, and we don't want to have to make patients come back time and time again.
Yeah.
So this all also lands on top of the broader squeeze where every year for the last 30 years, physician reimbursements have gone down relative to inflation. So over 30 years, doctors are making about 30% less than they used to. And once again, this is not a conversation about feel sorry for doctors.
Yeah.
Again, we still make a good living, but this would make it so that the practice closes, or we have to sell to a private equity group or a large hospital system who can absorb some of those extra costs.
Mm-hmm. It's simple finance. So when you're in a family or for your own personal budgets, you budget out your every month based off of what you are able to make.
Yeah.
And if all of a sudden somebody came in and said, I'm taking 50% or not 50% of a procedure, but you're removing a large portion of that budget every month, you're going to have to make adjustments in the way that you live.
Yeah.
You have to make adjustments in the way that you spend money, and it's the same exact thing for a practice. And so it's the practices are going to absorb costs, and it's this, especially the smaller practices that are going to take the biggest hit. And then what will end up happening is people will have to be going to emergency rooms. They're going to have to be going to bigger, larger facilities that can absorb a lot of different cost cuts like this. And then that's going to clog their systems, and it's longer waits, worse outcomes. And whereas if you come to our office, we can usually do everything all at once.
Another unintended consequence of rule changes like this is if you think about somebody who's been in medicine for a while and they've continued to face declining reimbursements and increased regulatory burden, more paperwork, more time sitting on a computer, checking boxes, and now with all of these cuts in aggregation, you're looking at a 10 to 25% reduction further in your take-home pay and in your ability to run an office. I truly believe that any doctor who is within 5 years of retirement is going to look really hard at leaving medicine early. Right now, Austin and I already see this, is that there are dozens, if not hundreds, of online groups for physician side gigs, meaning physicians who are looking for another career, another way to make money. And in many cases, if those take off, if they get into real estate, if they do, they will leave medicine entirely because of these burdens, when all we really want to do is provide excellent care to our patients. It's why we went into medicine.
Yeah.
And this will further exacerbate the doctor shortage, particularly in primary care, because this, again, is not just a dermatology problem. This is a medicine-wide problem. We're not trying to be all doom and gloom on you. There is something that you can do. So CMS proposed these rules on July 14th. And then there is a 90-day comment period where people can give comments. Now, you can comment directly to CMS, but those are not going to be as effective as contacting your 2 state senators and whoever your congressional representative is. You can email them directly on their websites. You can call their offices and leave comments. If you're going to leave a voicemail or you're going to talk to somebody on the phone, I would recommend that you talk to the legislative aide over healthcare. because every senator and every representative has somebody within their staff that focuses on different problems, and one of those is always going to be healthcare because it is a large part of the federal budget. So ask to leave that comment. Now, in the podcast show notes and on the YouTube video description, I'm going to have a link for you to look up who your representative is and who your senators are if you're unfamiliar with who represents you in Congress. And we will have a link to a Google document with a sample letter that you could send if you want to send an email. Now, it is important if you're going to use that sample letter that you read through it, and there's a section in there for you to put in something personal. Because if you're just sending in the exact same letter, it's not going to be as powerful as if you put in something personal, like, I have to drive 50 miles just to see my doctor, and I can't afford to do that twice. Or what your copay is, and if you're going to be required to pay 2 copays when normally it could be taken care of in one visit. So those kind of things are much more impactful if you're writing a letter or if you're talking to them on the phone. And we would highly encourage you, for the sake of your own healthcare, to make these phone calls or to send these emails to your senators and to your representative.
I tell my patients all the time, you are your best advocate in medicine. You know your body, you know yourself, and in this case, you know what your schedule is. You know what your budget is. You know if you can go to the doctor 3 or 4 times because your schedule allows it, that's perfect. But if your schedule doesn't allow it, you need to be an advocate for yourself in these types of instances, because that will make going to the doctor a more pleasant and more efficient experience.
And if you're not on Medicare yet, you will be someday, but maybe you care for somebody who is on Medicare, and this will directly impact them. And within a year or two, if Medicare pushes through these changes, we will see nearly every private insurer follow suit. There's some areas of the country where private insurances have already started to implement these changes. And what happens in the field of dermatology is that the offices drop these insurances, they no longer take them, or the doctors switch over to do more cosmetic procedures, so there's less time for actual medical care. And that's what I love to do. I don't do a ton of cosmetics because I prefer to focus on medical and surgical dermatology, the treatment of skin cancer. And so there are real world consequences to this, whether you have Medicare or not, because it will end up affecting all insurances. So please check out the links in the podcast show notes or on the YouTube video description so that you can contact your representatives and let your voice be heard, because that is the real purpose of the government, is to govern by the people.
Exactly right.
Thank you for joining us on this episode of the Skinfluence podcast. We highly encourage you to share this episode with a friend so that we can make a real difference in the way that healthcare is delivered in our country. We'll see you guys on the next episode.